This is case of the day, and we're on 108th case. Today is Wednesday, and the title is CT myelogram, a procedure that refuses to die or continues to live, whichever way you want to put it. 86-year-old, difficulty in walking, intermittent claudication, surgery 2 decades ago. That was the MR. There seemed to be canal stenosis at L45. Couldn't really see too much. The mass sequences weren't any better. The spine surgeon wanted a CT myelogram. Now, that was the instrumentation done during the earlier surgery. And in such situations, it's best to do the injection under CT guidance in the prone position, which is what I did. Injected 8 cc of iodinated contrast at the L3-4 level here. And so at L4-5, you can see the anterolisthesis. There is reduction in the thecal sac area. It's multifactorial. There's a disc, there's hypertrophy of the posterior elements, a little bit of facet, new osteophytes, some soft tissue here. And it's actually best seen on the axial plane because the coronal and sagittal almost show this to be normal. Then a little higher up at this level here, opposite the upper body of L4, there is this abnormal soft tissue with some facet osteophyte, which is compressing the thecal sac from the posterior aspect. And then lower down, and I looked at this after the surgeon asked me to comment on it, you can see a suture here, which is indenting or compressing the traversing left L5 nerve root. That's how these are MIPs that show the sutures. Now, which findings are responsible for the symptoms will all be sorted out by the spine surgeon depending upon the specific issues that the patient has. Now, there's a lot of literature on CT myelography for CSF leaks, using dynamic methods, etc. We don't do that, but probably the last paper on CT myelography of any relevance was 5 years ago, which was a review article in Radiographics, and these are all the indications that were mentioned. And we've done a few of these, and we perform CT myelograms on and off, maybe once in a couple of months. So this was many years ago before we started doing MRs routinely for people with pacemakers. Here we can see a canal stenosis at L4-5, which is again multifactorial disc, facet, ligamentum flavum thickening, etc. This was a 53-year-old, a lot of metal, and we did a Mars MR, didn't work out. And you can see that there's adjacent segment canal stenosis. If you remember, I did a post, I think last week or 2 weeks back on epidural fibrosis entrapping the nerve, and I talked about the causes of failed back syndrome. And one of them is adjacent segment disease. So this is adjacent segment disease at L3-4. There's anterolisthesis. And you can see on the axial image significant thecal sac compression on the CT myelogram. This was a patient many years ago in 2018, post-op GCT, lots of metal. There's no way we could, even with CT Mars, there was a problem. But you can see the pseudomeningocele formation, and the cord is very, very tiny and squashed here. Then was this patient where, again, there was a lot of metal, these laminectomies, there were compression fractures, the cord symptoms weren't going. And the myelo clearly shows that there is persistent compression because of the retropulsion of the conus. And this was again a few years ago, actually just a couple years ago. Again, lots of metal. And this patient had been operated for this gibbous, TB related, and wasn't improving, had paraplegia, and you can see here the cord is extremely thin and flattened, suggesting there's significant cord atrophy, and the Mars MRs wasn't really working. So you can see here that's really the cord, like a thin, lucent dot within the thecal sac, which is opacified by the contrast. So CT myelogram, apart from evaluation for CSF leaks, is an infrequently performed procedure, but it is still done, and so we should know still how to do it. And it's best done by injecting under CT guidance because that's very simple and straightforward, and we do it for specific indications on a case-to-case basis. That's the seminar now, just about 10 days away. My WhatsApp channel. Thank you so much for viewing this.